Meconium aspiration syndrome, a comprehensive review. Key statements. We present updated evidence and expert consensus to describe perinatal management, oxygen and respiratory support approaches, surfactant therapy, pulmonary hypertension of the newborn, PPHN, management, and other factors to consider in the care of neonates with meconium aspiration syndrome, MAS, Table 1. The time constant is the intubation and mechanical ventilation by optimizing lung recruit time required for the pressure to equilibrate between the alveoli meant and limiting oxygen exposure, and about 10 to 20% of infants are treated with continuous positive airway pressure, CPAP, alone in the proximal airway. Bolus surfactant has become an adjunct hypotension. Epinephrine is typically the agent of choice for its treatment for many infants with MAS, and a 2014 Cochrane review combined inotropy and vasoconstriction, with early data concluded that bolus surfactant administration may reduce the less effect on pulmonary vasoconstriction compared to severity of respiratory illness and decrease the need for dopamine. Directions. Meconium aspiration syndrome is a complex condition with variable severity and a wide range of respiratory, cardiovascular, and neurological comorbidities. While advancements in prenatal and perinatal management have resulted in a decreased incidence of MAS, significant associated morbidity and mortality persist. In the neonatal intensive care unit, NICU, treatment focuses on achieving adequate gas exchange while minimizing air trapping and pulmonary injury due to inflammation and atelectasis. Because associated PPHN can meaningfully contribute to morbidity and mortality, early identification and concomitant management of this complication is critical. Moving forward, studies exploring optimal modalities for ventilation and surfactant administration, as well as delivery room, DR, management and new therapeutics may guide future treatment and improve short and long-term outcomes for patients affected by meconium aspiration. Aspiration syndrome, MAS. Meconium aspiration syndrome, MAS, describes a neonatal respiratory illness secondary to aspirated meconium-stained amniotic fluid, MSAF, which is characterized by hypoxemia and respiratory distress. Meconium is the first stool of an infant, and is composed of cellular debris, amniotic fluid, vernix, lanugo, bile, pancreatic enzymes, and other substances of the digestive tract. Fetal distress or intrauterine hypoxia may trigger prenatal passage of meconium into the amniotic fluid. Aspiration of MSF can lead to airway obstruction, pulmonary inflammation, and surfactant inactivation. Some neonates present with only mild tachypnea, but others can experience severe respiratory failure. As meconium is rarely present in the lower intestinal tract prior to 34 weeks gestation, MAS is typically a disorder of full term, greater than or equal to 37-40 weeks gestation, near term, and post-term infants. Historical estimates of MSF incidence range from 7 to 22%, with MAS incidence between 0.5 to 2 per 1,000 live births. Advanced gestation has been associated with increased risk for MAS. A recent study from 2022 demonstrated an increase in MAS from 1.3% at 38 weeks to 4.8% at 41 weeks. Thick meconium, non-reassuring fetal heart tones and subsequent OPGAR score less than 7 at 1 minute all confer increased risk for MAS. There also appears to be an association between MAS and the method of delivery, with the highest rates of MAS occurring in infants who underwent emergency cesarean section. Planned home birth has also been associated with an increased risk of MAS, although these results are not uniform across studies. Additionally, some studies have suggested a link between increased incidence of MAS and certain maternal races/ethnicities, including Black American or African, Pacific Islander, and Indigenous Australian. A study of 132,884 term newborns in France found the incidence of MAS to be 7.9% and the overall incidence of MAS to be 0.2%, while a study of 2,490,862 neonates in Australia and New Zealand revealed rates of MAS as low as 0.35 per 1,000 live births. The incidence of MAS is reported to have decreased over recent decades. This overall decrease in the incidence of MAS is likely a result of improved prenatal care and surveillance in many countries around the world, as well as changes in obstetric practice resulting in fewer post-term deliveries with earlier induction dates and possibly more rapid response to non-reassuring fetal well-being during the labor process. Management of patients with MAS is frequently challenging. Infants may require significant cardiopulmonary support in the neonatal intensive care unit, NICU. MAS is associated with a significant risk of mortality and morbidities including persistent pulmonary hypertension of the newborn, PPHN, air leaks, and hypoxic ischemic encephalopathy, HIE. Meconium affects the respiratory system through multiple pathophysiological mechanisms. We broadly categorize contributing mechanisms below and in figure. Animal studies on the effect of meconium in the lung showed indicators of significant local inflammation. Bronchoalveolar lavage following meconium aspiration showed a significant increase in alveolar neutrophil counts and neutrophil chemotactic activity up to 48 hours after aspiration, in addition to significant influx of plasma protein. Additionally, there is an increase in inflammatory mediators including cytokines, interleukins, reactive oxygen species and complement activation in the lungs. This inflammation promotes the death of airway and alveolar epithelial cells in the setting of meconium aspiration. Large particles of aspirated meconium can block large airways, leading to severe hypoxia. The obstruction of smaller airways is more common and may lead to a ball valve-like effect. The increase in small airway diameter during inspiration makes this obstruction partial and allows for inflation of the alveoli distally. However, the decrease in small airway diameter during expiration leads to complete obstruction and prevents deflation of the alveoli. With recurrent breaths, this overdistension may result in pneumothorax and other air leak syndromes. Obstruction of small airways may also lead to alveolar collapse and ventilation perfusion mismatch. MOS is associated with increased functional residual capacity, FRC, and radiographic evidence of lung hyperinflation. Further, there is evidence of microvascular endothelial damage and fluid accumulation. Meconium directly damages the surfactant-producing type II pneumocytes. The inflammatory response in the alveoli and the components of meconium, including bilirubin and bile salts, change the chemical properties of surfactant and render it inactive. In experimental studies, the surface tension of alveoli increased progressively with the amount of aspirated meconium. In clinical studies, MOS is associated with decreased dynamic and static lung compliance, depicted by the pressure-volume loop in figure. Systemic inflammatory response and negative effect on the immune system. Meconium in the gastrointestinal tract is considered extracorporeal, and the immune system does not identify it as self. While MOS is largely thought of as a respiratory condition, a systemic inflammatory response likely contributes to the pathophysiology in addition to local lung inflammation. The changes in systemic markers of inflammation in neonates with MOS correlates with the severity of lung disease. Hofer et al. Reported on neonates with MOS without early onset sepsis and found these neonates to have significantly lower white blood cell counts, WBC, and absolute neutrophil counts, ANC, and elevated C-reactive protein, CRP, and immature to total neutrophil ratios, IT ratio. A systemic inflammatory effect mediated through the complement system may also play a role in the pathophysiology of MOS. Alveolar macrophages have reduced phagocytic and respiratory burst activities in the setting of meconium aspiration, while neutrophils have similarly reduced phagocytic activity. In vitro studies have suggested a role for pancreatic enzymes in the pathogenesis of MOS based on the protective effect of protease inhibitors on epithelial cells. Persistent pulmonary hypertension of the newborn, PPHN. One of the most significant sequelae of MOS is PPHN, which results from impaired fetal to perinatal physiologic transition. Conversely, in term newborns, MOS represents one of the most significant risk factors for PPHN. In MOS, sick lungs and hypoxia contribute to PPHN. Here, pulmonary vascular resistance, PVR, which is elevated throughout fetal development, fails to decrease sufficiently after birth to permit adequate pulmonary blood flow required to achieve oxygenation through newly inflated neonatal lungs. Inadequate oxygenation results in further hypoxemia, which may vary from mild to critical across the spectrum of disease severity. Important to consider in its therapeutics, MOS PPHN is typically associated with normal fetal pulmonary and cardiovascular development, such that elevated PVR occurs in the context of a reactive pulmonary vascular bed with sick lungs causing pulmonary vasoconstriction rather than underlying pulmonary vascular maldevelopment more associated with fixed elevations in PVR. The presence of MSF is a prerequisite for MOS. Aspiration of this MSF perinatally triggers the pathophysiologic cascade that results in MOS. Clinically, neonates with MSF may range from asymptomatic to symptomatic. Neonates with true MOS demonstrate respiratory symptoms shortly following delivery, including tachypnea, cyanosis, grunting, and increased work of breathing. Additionally, a hyperexpanded thorax or barrel-shaped chest may be apparent, and evidence of meconium staining may be present on the skin, hair, nails, and umbilical cord. Rales and rhonchi may be heard on auscultation. Across the spectrum of disease severity, neonates with MOS may range from vigorous with only mild tachypnea and minimally decreased oxygen saturations to severely depressed with high and hypoxic respiratory failure. Classically, chest radiograph in MOS demonstrates pulmonary hyperinflation with patchy infiltrates alternating with areas of atelectasis. However, radiological findings may be variable and disease severity by imaging does not correlate with clinical disease severity. Arterial blood gas may show low PaO2 levels consistent with hypoxemia. Respiratory alkalosis may be present initially due to tachypnea and hyperventilation, but respiratory acidosis may also be seen with hypercarbia. With increasing disease severity, hypoxia often coupled with metabolic acidosis can affect the cardiovascular status and impair tissue oxygen delivery, further driving PPHN, cardiac dysfunction, and potential for end organ injury. The hallmark of PPHN is hypoxemia with differential saturations. Elevated pulmonary vascular pressures result in right to left shunting across the ductus arteriosus, producing a gradient observed between higher preductal saturations and lower postductal saturations. With severe or advanced disease, sequelae of right heart and eventual left heart failure are observed, including hypotension and lactic acidosis. Clinically, neonates with PPHN may be highly labile with respect to saturations and other vital sign parameters, with poor tolerance for lights, sounds, and other stimuli. The differential diagnosis for MOS includes transient tachypnea of the newborn, sepsis, cyanotic congenital heart disease, as well as neonatal respiratory illnesses such as pneumonia, respiratory distress syndrome, RDS, pneumothorax and other air leak syndromes, developmental lung abnormalities including congenital airway and lung abnormalities, such as congenital pulmonary adenomatous malformation, thoracic or pulmonary masses, and alveolar capillary dysplasia, among others. Most often, a clinical history of MSF combined with postnatal hypoxemia and characteristic chest radiographic findings help differentiate MOS from other neonatal cardiac and respiratory conditions. The following diagnosis of MOS has been utilized in clinical trials: respiratory distress in a neonate born through MSF. Supplemental oxygen required to maintain oxygen saturations. Oxygen requirement beginning in the first 2 hours of life and lasting for 12 hours or longer. Absence of congenital malformations of the airway, lung, or heart. PPHN can be diagnosed clinically by the presence of differential saturations, with greater than or equal to 10 percentage point difference between higher preductal and lower postductal saturations, reflecting shunting of deoxygenated blood from the pulmonary artery into the aorta. Formal diagnosis relies on echocardiography, which is also important to rule out accompanying congenital heart disease, which may complicate cardiopulmonary management or contribute to cyanosis, and to guide optimal choice of therapeutics. While consensus definition in neonatal populations are problematic, echocardiographic findings supporting PPHN include elevated pulmonary artery pressure measurement, leftward deviation of the interventricular septum, tricuspid regurgitation, bidirectional and or right to left flow across fetal shunts, ductus arteriosus, patent foramina valley, as well as right ventricular hypertrophy, dilation, or dysfunction. MOS and PPHN disease severity can be assessed using the oxygenation index, OI, ideally calculated from a preductal arterial sample. OI equals mean airway pressure times FiO2 times 100, PaO2, where FiO2 equals fraction of inspired oxygen. Generally, OI values less than or equal to 15 reflect mild respiratory disease, while levels greater than or equal to 25 reflect severe hypoxic respiratory failure. Alternatively, OI can be estimated using the preductal oxygen saturation to calculate an oxygen saturation index, OSI, where OC times 2 approximates the OI value. OC equals mean airway pressure times FiO2 times 100, preductal oxygen saturation. Optimal management of MOS begins in the prenatal period and extends well beyond delivery. We present updated evidence and expert consensus to describe perinatal management, oxygen and respiratory support approaches, surfactant therapy, PPHN management, and other factors to consider in the care of neonates with MOS. Table. Recommendations for the perinatal management of neonates born through MSF have evolved dramatically over the past few decades. Based largely on limited data from the 1970s, obstetric practice up to 2005 consisted of suctioning the nasopharynx and oropharynx after the delivery of the fetal head, but before the delivery of the shoulders and body. Since 2005, this is no longer recommended because it was found to be associated with increased DR morbidity and or need for DR resuscitation, as well as ineffective in preventing or altering the course of MOS. Amnio infusion has also been trialed to decrease the risk of MOS, with the goal of diluting the meconium and relieving cord compression if oligohydramnios is also present. However, a large RCT in 2005 found no reduction in the incidence of MOS or perinatal mortality with this practice. A Cochrane review again supported this conclusion in 2010. Since 2006, the American Academy of Obstetricians and Gynecologists, ACOG, no longer recommends routine amnio infusion for the reduction of MOS. From a neonatal standpoint, resuscitation recommendations for infants born through IMSF have evolved significantly. In the 1990s there was a shift of practice from routinely intubating and suctioning the airway of all infants born through thick IMSF to only intubating and suctioning non-vigorous infants. The shift occurred following evidence that routine intubation and suctioning of vigorous infants with IMSF did not decrease the incidence of MOS and could potentially cause laryngopulmonary complications. The 2000 Neonatal Resuscitation Program, NRP, guidelines reflected this practice change. Routine tracheal intubation and suctioning of all non-vigorous infants with IMSF remained the standard of care until 2015. An RCT from India demonstrated that routine endotracheal suctioning in non-vigorous neonates with IMSF did not significantly reduce the risk of MOS or its associated morbidity. Due to insufficient evidence, the 2015 American Heart Association guidelines no longer recommended this practice, and this change was reflected in the NRP 7th edition. The focus was placed on initiating steps of resuscitation, positioning the airway, suctioning the mouth and the nose, drying, stimulating, and not delaying delivery of positive pressure ventilation, PPV, to infants without respiratory effort. Endotracheal intubation could still be appropriate in non-vigorous infants for whom meconium was obstructing the airway and preventing effective PPV. A retrospective study of DR management noted that recovery of meconium below the cords was observed in 47% of infants who developed MOS, supporting the theory that aspiration of meconium often takes place in utero. Although the evidence is of low certainty, these 2015 recommendations have remained in place for the NRP 8th edition as the majority of evidence continues to suggest that routine endotracheal suctioning of non-vigorous neonates does not decrease the incidence of MOS. Respiratory support for MOS ranges from the delivery of oxygen therapy, nasal cannula, oxyhood, high-flow nasal cannula, to continuous positive airway pressure, CPAP, to mechanical ventilation in more severe cases. First, considerations for assessment and monitoring in patients with MOS beyond the DR, which should be individualized to disease severity. Both pre- and post-ductal saturation monitoring should be performed in the presence of an open ductus arteriosus to enable minute-to-minute monitoring of ductal shunting, which will reflect relative pulmonary to systemic pressure differentials. Because PPHN results in right to left ductal shunting, pre-ductal saturation should be used to adjust therapies and oxygen supplementation. Key indices for serial monitoring include pre-ductal saturations, POW2 values, and OI. Universally, consensus guidelines support target preductal oxygen saturation goals with aggressive avoidance of hyperoxemia and hypoxemia. Across literature, a target saturation range with lower limit of 91 to 92% and upper limit of 95 to 97% appears consistent. Because oxygen is a potent pulmonary vasodilator, avoidance of extremes in either direction will support clinical stability and minimize injury. Animal models suggest a clinically important inflection point in hypoxic pulmonary vasoconstriction at preductal POW2 values around 60 mm of mercury, such that contemporary recommendations suggest targeting a preductal POW2 of at least 60 to 80 mm of mercury. Further, animal and neonatal studies demonstrate that while supplemental oxygen accelerates the rate of PVR decrease after birth, persistent hyperoxia contributes to inflammation, developmental lung injury, oxidative stress, and diminishes subsequent nitric oxide responsiveness. Assessment and monitoring of moderate to severe MOS and associated PPHN may be best achieved with continuous hemodynamic monitoring and frequent blood gas/lactate laboratory evaluation during the acute phase. For sicker patients, arterial access via right radial arterial line should be prioritized over umbilical arterial catheterization to permit pre-ductal assessments and OI calculations. Serial arterial blood gas measurements can be particularly important in caring for MOS PPHN, as expert consensus provides guidelines to target for pH, POW2, PaCO2. Serum lactate may be useful as an objective marker of tissue perfusion. Increasingly, B-type natriuretic peptide, BNP, NT-proBNP, is being recognized as an important clinical biomarker in PPHN representing right heart strain, with utility in trending disease status and response to therapies. In the setting of full-term and near-term neonates with normal fetal lung development, normoventilation is recommended with a target PaCO2 level of 45 to 60 mm of mercury. In mild MOS, supplemental oxygen, most commonly in the form of a nasal cannula or oxyhood, is often all that is required. The goal of supplemental oxygen is to provide adequate oxygenation, which is one of several essential factors in helping to prevent or minimize the effects of PPHN. Historically, supplemental oxygen alone, nasal cannula or oxyhood, had often been the preferred treatment of mild MOS, in an attempt to limit risk of air trapping and resultant air leak. Current recommendations favor the least invasive form of respiratory support in the management of MOS, while still ensuring adequate oxygenation and ventilation. The use of CPAP in MOS has been proposed as a way of preventing intubation and mechanical ventilation by optimizing lung recruitment, setting PEEP at 6 to 8 cmH2O, and limiting oxygen exposure, and about 10 to 20% of infants are treated with CPAP alone. The respiratory management of these infants is complex due to the presence of both atelectasis and hyperinflation, and the degree of pressure required will be unique for each patient. Although there is an increased risk of air leak, known benefits of CPAP include improvement in atelectasis, reduced air trapping, and decreased ventilation perfusion mismatch, ultimately improving gas exchange. A 2018 RCT demonstrated a reduced need for mechanical ventilation in the first 7 days of life utilizing low-level CPAP, 5 cmH2O, versus oxyhood support. This study concluded that early use of CPAP compared to oxyhood resulted in 1 newborn avoiding mechanical ventilation for every 5 newborns with MOS. In current practice, about 1/3 of patients with MOS require endotracheal intubation and mechanical ventilation. Earlier studies reported higher rates of intubation, with Hofer et al. Reporting invasive mechanical ventilation rates of 76% for infants with MOS from 1990 to 2010, while more recent population-based studies report intubation and mechanical ventilation in 35% of MOS patients. In our practice, endotracheal intubation is generally indicated when the FiO2 reaches 60%, for hypercapnia with PaCO2 greater than or equal to 60, or for pH less than 7.25. Hemodynamic instability with low blood pressure and poor systemic perfusion is another indication for mechanical ventilation. When non-emergent, we preferably perform endotracheal intubation with premedication for sedation. Appropriate size endotracheal tube should be selected, which is usually a size 3.5-4 mm, internal diameter, tube for most term neonates. In animal models, partial liquid ventilation with surfactant administration resulted in improved surfactant distribution and oxygenation. However, no studies to date have evaluated liquid ventilation in humans. In current practice, the mode of ventilation depends primarily on clinician and unit-level factors. While large, prospective RCTs comparing modes of ventilation for infants with MOS do not exist, observational studies and smaller trials have shown improved short-term outcomes with high-frequency ventilation, HFV, including shorter duration of intubation, greater improvement in PaO2, and reduced incidence of air leak. CMV is the most widely used ventilatory mode for infants with MOS. Specific settings are largely based on clinical experience and physiological reasoning. A recently published study found that infants with MOS require higher tidal volume, VT, mean plus or minus SD of 6.11 plus or minus 1.05 ml/kg, and minute ventilation, 371 plus or minus 110 ml/kg per minute, compared to VT of 4.86 plus or minus 0.77 ml/kg and minute ventilation of 262 plus or minus 53 ml/kg per minute for infants without MOS. The following provides details for specific ventilator parameters. Settings for positive end expiratory pressure, PEEP. Choosing the PEEP level should balance maintaining FRC with adequate pressure against the potential risk of reduced oxygenation and pneumothorax with hyperinflated lungs. In an earlier study, Fox et al. Reviewed the response of 14 patients with MOS to various levels of PEEP. Some of these patients were breathing spontaneously and received nasal CPAP, while others received mechanical ventilation via endotracheal tube. This historical study has suggested an optimal PaO2 response demonstrated at PEEP of 4 to 7 cmH2O for MOS. Clinically, a PEEP of 5 to 8 cmH2O is generally used depending on observed atelectasis and hyperinflation. Settings for inspiratory time, IT, and rate. The time constant is the time required for the pressure to equilibrate between the alveoli and the proximal airway. It takes 3 time constants to discharge 95% of the tidal volume on expiration. The time constant varies with both airway resistance, RA, and lung compliance, CL, with time constant, KT, equals CLXRA. The inspiratory KT is shorter than the expiratory KT because airway resistance is lower during inspiration due to airway dilation. With insufficient time for expiration, incomplete emptying of the lungs may result in increased pressure within the airways and alveoli, leading to auto-PEEP. This increases the risk of pneumothorax and negatively affects oxygenation. The optimal ventilatory rate and it should minimize the risk of incomplete expiration and the development of auto-PEEP. Generally, ventilatory rate is set at 30 to 40 breaths per minute or less, with it usually between 0.35 to 0.4 s. However, it as high as 0.5 s has been reported. Settings for peak inspiratory pressure, PIP. PIP should be sufficient to help open the areas of the lung with atelectasis and reduced compliance. Depending on the degree of parenchymal disease, increased PIP may be required. When PIP requirements approach 30 cmH2O, high-frequency ventilation should be considered to minimize lung injury, overdistension, and air leak. Alternatively, volume ventilation has been suggested by several groups, with a mildly increased proposed target VT around 6 ml/kg. HFV may help protect the lungs from both alveolar overdistension, volutrauma, and alveolar collapse, atelectotrauma. Despite limited population-specific clinical studies, HFV has become an important tool in the management of infants with MOS. About 1/4 of infants with MOS requiring mechanical ventilation are treated with HFV, with reported use increasing over time. High-frequency oscillatory ventilation, HFOV, is the most frequently used mode of HFV, followed by high-frequency jet ventilation, HFJV. HFV may be used as a primary ventilatory approach or as rescue mode following CMV. Transitioning to HFOV usually occurs in the setting of persistent hypercapnia, air leak, or when combined with nitric oxide, ENO, in the setting of PPHN. Importantly, Kinsella and colleagues demonstrated that lung recruitment with HFOV augmented ENO responsiveness in MOS. A stepwise recruitment maneuver using oxygenation as an indirect indicator of lung inflation helps in identifying the ideal mean airway pressure, PAW, to optimize lung volume. In our unit, these infants usually require PAW of 16 to 22 cmH2O for optimal oxygenation. HFOV frequency is usually set at 8 to 10 Hz. Considering HFJV, preclinical studies have shown beneficial effect in MOS, and Dargaville reported on infants with MOS improving on HFJV after transitioning from HFOV using a low frequency, 240 to 360 BPM, combined with low CMV rate. Heliox has been clinically used in the management of many pediatric respiratory diseases including asthma and bronchiolitis. Heliox is a gas composed of a higher percentage of helium, usually 70 to 80%, and a lower percentage of oxygen, usually 20 to 30%. Helium is a naturally occurring gas with low density, whose physical properties support laminar flow even with small diameter airways prone to turbulent flow. A recent RCT compared outcomes of mechanically ventilated infants with MOS who received Heliox for 6 hours followed by blended oxygen and air against those receiving blended oxygen and air. In this study, infants with MOS treated with Heliox had significantly better oxygenation as measured by PAO2/VO2, shorter time on mechanical ventilation, and decreased hospital length of stay. Although this study and others have established feasibility of Heliox in infants with MOS requiring mechanical ventilation, more studies are needed to operationalize its use clinically in this population. MOS-associated surfactant inactivation can be treated with exogenous surfactant, which has been shown to improve oxygenation and lung compliance in animal models. There are two main ways surfactant can be administered: through a bolus dose, as is used to deliver surfactant to infants with RDS, or via surfactant lung lavage. Bolus surfactant has become an adjunct treatment for many infants with MOS, and a 2014 Cochrane review concluded that bolus surfactant administration may reduce the severity of respiratory illness and decrease the need for extracorporeal membrane oxygenation, ECMO. Further, reduction in the need for ECMO with bolus surfactant was one conclusion in a 2016 systematic review. Several RCTs and systematic reviews have looked at the use of lung lavage with dilute surfactant. The goal of surfactant lung lavage is not only to replace surfactant, but also to remove meconium and debris from the lung, thereby improving lung function. Although the evidence is inconsistent, the use of surfactant lavage for MOS appears to be safe. A 2012 systematic review and meta-analysis found surfactant lavage therapy to decrease death or need for ECMO. However, this conclusion was of low-quality evidence because of a total sample size less than 100 in the 2 RCTs included in these studies. 2 additional RCTs concluded that while surfactant lung lavage was well tolerated, it did not alter the duration of respiratory support. Similarly, A 2020 meta-analysis concluded that surfactant lavage improved OI and reduced duration of mechanical ventilation but did not shorten the duration of oxygen therapy or hospital stay. While surfactant appears beneficial in MOS, the superior route of administration is less clear. A 2016 review comparing bolus to surfactant lavage found both routes to reduce the duration of mechanical ventilation and hospital stay. Subsequently, a 2019 RCT concluded no additional benefit to surfactant lavage over bolus surfactant in MOS. In patients with MOS, PPHN is associated with significant morbidity and mortality, such that timely diagnosis and optimal management is critical. For MOS PPHN, management is similar to that for PPHN across neonatal populations. Support pulmonary blood flow and systemic oxygen delivery through support of cardiac function and systemic blood pressure, as well as targeted pulmonary vasodilator therapies. However, we endeavor to highlight when research has identified strategies unique to MOS PPHN. As a general rule, core management aims include cardiopulmonary optimization, adequate tissue oxygen delivery, and avoidance of iatrogenic injury. Given that pulmonary disease represents a key underlying pathophysiologic mechanism responsible for hypoxemia and pulmonary vasoconstriction, lung recruitment and pulmonary optimization remain the key initial interventions for MOS PPHN. Pumping against elevated pulmonary pressures causes right heart strain, resulting in potential for right heart dysfunction and failure. Compounded by the effects of hypoxia, acidosis, and other factors, unsupported right-sided heart failure leads to decreased left heart filling, left-sided dysfunction and diminished cardiac output, with ultimate risk for systemic shock. Therefore, the choice of inotropic agent should be patient-specific to disease state and pathophysiology, with careful consideration of therapeutic goals. While dopamine remains the most widely studied cardiovascular agent in neonates, studies suggest the risk-benefit profile of other agents may be superior in the treatment of PPHN. Dopamine's non-selective systemic and pulmonary vasoconstriction make it particularly problematic in the PPHN population, for whom a major therapeutic goal is reduction of PVR. Rather, expert consensus supports the choice of dobutamine and/or epinephrine to support cardiac function in PPHN. Dobutamine acts as a pure inotrope without vasoconstrictor properties, making it an excellent choice to support right heart function in the setting of adequate systemic blood pressure, without concomitant increases in PVR. When cardiac dysfunction is compounded by hypotension, epinephrine is typically the agent of choice for its combined inotropy and vasoconstriction, with early data suggesting less effect on pulmonary vasoconstriction compared to dopamine. In PPHN patients with preserved cardiac function but with inadequate systemic blood pressure, vasopressin is increasingly utilized as a systemic vasoconstrictor with reported improvements in both oxygenation and systemic perfusion. At current, studies are exploring norepinephrine and other cardiovascular agents, however data remains lacking to clearly support their use in the PPHN population. While historically relegated to cardiac and cardiac surgical populations, milrinone is now widely utilized in PPHN, particularly in the setting of right or left heart dysfunction once appropriate blood pressure has been established. Milrinone, a phosphodiesterase, parade 3 inhibitor, improves cardiac inotropy and lucidropy, with the additional benefit of pulmonary vasodilation through its effects on the prostacyclin CAMP pathway. Milrinone may additionally provide synergistic pulmonary vasodilation when combined with other pulmonary hypertension agents. However, milrinone may also decrease systemic blood pressure through non-selective vasodilation and relies on renally mediated clearance, requiring caution and thoughtful consideration for appropriate therapeutic candidates. While few head-to-head vasodilator trials exist for the PPHN population, one recent RCT comparing milrinone to sildenafil reported superior oxygenation among milrinone-treated patients and no significant hypotension among either group. Prostaglandin E1, PGE1, has a long clinical history in neonatal ductal-dependent critical congenital heart disease, utilized to maintain patency of ductus arteriosus for support of pulmonary or systemic perfusion as a bridge to cardiac surgical intervention. More recently, PGE1 has been considered as rescue therapy in severe PPHN to preserve ductal patency with the goal of offloading a failing right ventricle. One small retrospective study suggested benefit in PPHN when neonates with hypoxic respiratory failure, but not ductal-dependent congenital heart disease, were administered PGE1. While no studies have specifically explored PGE1 use in MOS PPHN, its use is increasingly supported in diverse PPHN populations associated with suprasystemic pulmonary artery pressures and/or right ventricular failure. Glucocorticoids represent another potentially important therapeutic agent, particularly in MOS PPHN owing to their anti-inflammatory effects. While early studies proved inconclusive, More recent studies exploring mechanisms of action suggest clinical benefit. Animal and clinical studies suggest hydrocortisone improves oxygenation and may attenuate oxidative stress. As an added benefit, one study additionally reported improved systolic blood pressure among neonates with PPHN following hydrocortisone administration. Within the lungs, three major biochemical pathways drive PVR: nitric oxide pathway, NO-cGMP, prostacyclin pathway, PGI2-CAMP, and endothelin pathway. All currently available pharmacotherapy targets for pulmonary hypertension act on one of these three vasoreactive pathways. The first vasodilator therapy utilized in the management of MOS is oxygen, itself a potent pulmonary vasodilator. However, judicious oxygen supplementation to achieve target productyl saturations while avoiding hyperoxia is critical to support clinical stability and minimize lung injury. Inhaled nitric oxide, ENO, targets the NO-cGMP pathway and is the only FDA-approved agent for PPHN, with demonstrated reduction in need for ECMO. Therefore, once lung optimization is achieved, ENO is the first-line pulmonary vasodilator therapy for term and near-term infants with OI greater than or equal to 25. Specific to MOS PPHN, one study reported decreased duration of ventilation and oxygen support following treatment with ENO. Particularly among patients with MOS PPHN, improved oxygenation in response to ENO therapy is amplified with the synergistic effect of FOV. However, significant ENO non-responders/transient responders have limited its utility as the panacea for PPHN. Further, limited historic data suggests less significant and/or unsustained ENO responses in the setting of MOS compared to idiopathic PPHN, surmised to be the result of underlying ventilation perfusion mismatch and airway obstruction characteristic of MOS. Sildenafil, a PDE5 inhibitor, also exerts its effects through the NO-cGMP pathway. While FDA warnings around the use of sildenafil in children must be considered, both U.S. and European expert consensus guideline statements support consideration for sildenafil in PPHN, in either oral or intravenous preparation and as monotherapy or adjunct therapy, especially when ENO is unavailable or fails to sufficiently improve oxygenation. Prostacyclin analogs represent the class of pulmonary vasodilator medications targeting the PGI2-CAMP pathway. Formulations exist as inhaled, intravenous, and subcutaneous infusions. While less studied in pediatric and neonatal populations than ENO or sildenafil, early studies appear promising, and current guidelines support consideration for the use of prostacyclin analogs as an adjunct therapy in PPHN. Normalization of acid-base status since acidosis exaggerates hypoxic pulmonary vasoconstriction, correcting severe metabolic acidosis to target a pH 7.25 to 7.4 during acute stabilization is recommended. Figure. ECMO has a well-established history in the treatment of severe MOS PPHN. Historically, the first neonate successfully treated with ECMO in 1975 was a one-day-old with MOS. While MOS once comprised a majority percentage of the neonatal conditions for which ECMO was utilized, decreased frequency of MOS over recent decades has translated into decreased ECMO use for MOS PPHN. Importantly, survival rates following ECMO for MOS PPHN remain excellent, with recent data suggesting survival beyond 90%, likely reflecting the reversible nature of this cardiopulmonary disease. Today, ECMO is indicated to improve survival in severe MOS PPHN with inadequate or unsustained response to cardiopulmonary medical optimization. Extracorporeal Life Support Organization, ELSO, guidelines support the following criteria for ECMO initiation in neonates with severe cardiorespiratory failure: inadequate tissue oxygen delivery on maximal medical support, acute decompensation with severe hypoxic respiratory failure, persistently elevated OI, or severe pulmonary hypertension with cardiac dysfunction. Antibiotics. Infants with MOS are often treated with antibiotics. However, the evidence to support this practice is lacking, with several RCTs finding no benefit in the routine use of antibiotics in the treatment of MOS. In addition, recent systematic and Cochrane reviews found no benefit for the use of antibiotics in MOS and no difference in infection rate. Sedation/paralysis. In MOS and MOS PPHN, avoid unnecessary stimulation and agitation, and ensure pain is adequately controlled to minimize ventilator asynchrony and pulmonary vasoconstriction. The goal is to alleviate noxious stimuli and agitation to better synchronize CMV, improve the response to HFV, and minimize pulmonary hypertension. Universally, expert consensus supports sedation when needed, titrated to achieve cardiopulmonary stability. Commonly used medications include opioids, morphine and fentanyl, benzodiazepines, midazolam, and central alpha-2 agonists, dexmedetomidine. However, no studies to date have explored optimal drug choice in this population. Importantly, routine use of paralysis should be avoided as its use was reported to be associated with increased mortality. MOS is associated with short and long-term complications. In the short term, respiratory complications include air leak syndrome and pneumonia. Broadly, median duration of intubation and ventilation in MOS is 3 days. Severity of illness correlates with morbidity. One study of 9,295 infants with MOS showed that more severe disease was associated with a 3-fold increase in ppHN, 5-fold increase in high, and nearly double the length of hospital stay. In another large study, 5% of neonates with MOS required oxygen support at 28 days or discharge, and 4.9% experienced seizures. In longer-term follow-up studies, school-age survivors remain at increased risk for pneumonia as well as airway hyperreactivity and alveolar hyperinflation. Further, neurodevelopmental follow-up among MOS survivors reveals common deficits, regardless of the mode of delivery, vaginal versus cesarean, or treatment, conventional ventilation, ENO, or ECMO. One study found a 7% incidence of cerebral palsy and 14% incidence of severe global developmental delay, while an additional 41% were diagnosed with mild speech delay or hypotonicity without a motor or abnormality. MOS is also associated with significant mortality, with case fatality rates as high as 40% in past decades, although significantly reduced mortality is seen in the modern era with improvements in perinatal and neonatal management. In a 2009 study of 162,075 term neonates with MOS admitted to a U.S. NICU, mortality was 1.2%, with similarly low mortality rates reported in large contemporary studies. Causes of mortality may include progressive respiratory failure, air leak, septic shock, and pulmonary hemorrhage, with severe MOS disease conferring a 4-fold risk of death prior to hospital discharge. Compared to survivors, neonates who die from MOS are likely to be smaller, have a lower 5-minute OPGAR score, and require more intensive care including mechanical ventilation, surfactant, ENO, antibiotics, steroids, vasopressors, and anticonvulsants. Meconium aspiration syndrome is a complex condition with variable severity and a wide range of respiratory, cardiovascular, and neurological comorbidities. The pathophysiology of MOS is multifactorial and includes both pulmonary and systemic pathways. While advancements in prenatal and perinatal management have resulted in a decreased incidence of MOS, significant associated morbidity and mortality persist. In the DR, aggressive perinatal suctioning and routine intubation are no longer recommended. In the NICU, treatment focuses on achieving adequate gas exchange while minimizing air trapping and pulmonary injury due to inflammation and atelectasis. The mainstays of therapy are supplemental oxygen, respiratory support, and consideration for surfactant therapy. While studies have explored various ventilatory modalities, evidence to date does not clearly support any singular modality as superior, such that respiratory management should be individually targeted to the patient's pathophysiology, symptom severity, and clinician/unit expertise. Because associated ppHN can meaningfully contribute to morbidity and mortality, early identification and concomitant management of this complication is critical. Moving forward, studies exploring optimal modalities for ventilation and surfactant administration, as well as DR management and new therapeutics may guide future treatment and improve short and long-term outcomes for patients affected by meconium aspiration.